Today, we are super fortunate to have Dr. Kochar here. He is from Brigham and Women's Hospital, and Mike is going to give a little intro, a little bit more about who he is and what he does.
Thanks, Jen. So it's my pleasure to introduce Dr. Ajar Kochar. He's an esteemed interventional cardiologist and researcher at the Brigham and Women's Hospital and Harvard Medical School. Ajar completed his medical school at Brown. He did his residency at a small hospital in Baltimore, and then his fellowship and interventional fellowship at Duke. He is the program director for the Interventional Cardiology Fellowship at Brigham, and he's really considered a leader in both cardiogenic shock management and complex coronary interventions. He's got an extensive research portfolio, multiple grants from different sponsors. And he's been, recognized for his contributions both in medical education and then also in clinical innovation. So he's really a true triple threat as a clinician, educator, and researcher. Um, and on a personal note, I met Ajar 10 years ago, actually, when I interviewed for cardiology fellowship. He was 2 years ahead of me, cathing with Manesh Patel, Jepta's friend, and we've really been great friends ever since. And it's been incredible to see his career flourish over the years. And I can confidently say that he's one of the most dedicated and talented clinicians in the field. So today he's going to be sharing his insights on cardiogenic shock considerations for the cath lab. So please join me in welcoming Audra.
Mike and Jen, thank you so much for that incredibly gracious and overly exaggerated introduction. I feel very, very privileged to talk to this group here. A lot of friends at Yale, a lot of people both from Hopkins and from Duke, where I trained previously, that have not only ended up at Yale, but really have been leaders both locally and now nationally. So it's been really fun to watch. As Mike mentioned, I am the interventional program director. And so when Jen invited me to make this talk, I sort of designed it to be a little bit more interactive. So if there are fellows on the call, I may pause and ask you guys questions, and we'll go from there just to make it more interactive. But overall, the focus of this talk will be sort of cardiogenic shock considerations for the cardiac catheterization laboratory. These are my pertinent disclosures. I think these kind of talks are best framed by a case discussion. So a few months ago, I took care of an 81-year-old woman with a relatively insignificant past medical history, presented with an anterior STEMI at Martha's Vineyard. Um, the symptom onset was at least 8 hours, probably longer than that, because she was found by her granddaughter. And the first medical contact to Brigham ED time was about 2.5 hours, taking into consideration the helicopter ride from Martha's Vineyard to Boston. Uh, at Martha's Vineyard, she had received aspirin and metoprolol, and I think they were starting heparin en route. And as you can see, for her initial clinical status, she was still having active chest discomfort. Her heart rate was elevated, her blood pressure was fine, and she was, from a respiratory standpoint, doing okay. It's clear that the MI was evolving because her initial high sensitivity troponin was 500, her lactate was low normal, and her other lab values were okay. You can see that she pretty quickly started developing some respiratory distress with the face mask on. When by the time we got her to the cath lab, this was the initial shot that we took.
Mhm.
And with the second puff of contrast, her blood pressure crashed, and she desaturated further. So maybe I'll have the fellows just sort of think about what they would do next, and we'll sort of continue with the talk from here. I'll start off by just outlining the sort of contemporary basics of cardiogenic shock, so characteristics and prognosis. I'll delve a little bit into technical considerations in the cath lab, so really oriented towards sort of technical considerations for our fellows. And then I think transition a little bit more into the data with a focus on how we ought to think about shock management in a post-danger shock era. And with a focus again on thinking about complications and mitigating complications. And then I'll leave with a wild tangent that is off of shock completely. And I'll leave you with that mystery if we have time. So we'll start with the basics of shock. So this is a nice paper led by my colleagues right here at the Brigham, by Dave Berg and Dave Morrow from the Critical Care Cardiology Trials Network, which is a network of CICUs. I believe Yale's a participating site with Elliot Miller leading the charge there. And what they looked at was what is the mix of cardiogenic shock in contemporary ICUs. And you can see that only 2/3 of shock that comes to cardiac ICUs is actually cardiogenic, with a full third being a differential cause. And even amongst cardiogenic shock presentation, there is a varied cause of cardiogenic shock. And the most common causes are MI, but actually even more common than MI in the contemporary setting is heart failure related cardiogenic shock, being the two most common causes of shock. And as an overarching theme, what I would say is it's really important to understand that shock is a very heterogeneous disease state, which I think accounts for a lot of the variability, both in outcomes and then challenges of studying it from a disease state. As a follow-up from our prior comment that the two most common causes of shock are MI and heart failure, I think it's very important to acknowledge that there are major differences in the natural history. And as a result of that, in the outcomes of patients who are presenting with MI shock versus heart failure shock. So this is led by an analysis led by Jacob Abraham that shows in this top panel that patients with MI shock are oftentimes ambulatory, very rapidly decompensate, where as opposed to the patients with heart failure shock can be much more dynamic and have a more slower progression. And so to provide more detail around this progression of the natural history of shock, for AMI shock, the initial presentation tends to be hypotension. That hypotension then leads to hyperperfusion, and then patients end with congestion. For heart failure shock, it's almost completely inverted. So patients tend to present with congestion first. As a result of that congestion, they start to develop hyperperfusion. And then as a consequence of the prior two factors, they then slowly or sometimes rapidly will progress to hypotension. Another key concept for cardiogenic shock is that it is a very dynamic disease state and very rapidly evolving. So this is an elegant analysis for the cardiogenic shock working group led by Naveen Kapoor that we had the privilege of writing the editorial for. And what they did with this analysis is that they stratified patients by their presentation or their admission SCI classification, and then followed them through their hospitalization. And what they saw was that 90%, let me repeat that number again, just because of how staggering it is. 90% of patients who presented with SCI B shock presented to a higher SCI stage during their hospitalization, and almost 70% of patients with SCI C shock progressed to a higher stage within the matter of about 2 hours. So I think it's humbling for those of us who are caring for these patients that we need to be anticipating this rapid evolution. And the question is sort of how do we do that? And there are a variety of different ways to do that. But I think to further cement this concept, I think for the fellows, we need to acknowledge that things change with time. So for example, when Dr. Nana was just a kid in Italy, as a 7-year-old, his dream was to go to America and play for the Yankees. But over time, things change. And as in his mid-30s now, his dreams are to respond to reviewer two's comments. But going back on a more serious note, how can we evaluate? Well, I think serial lactate. So there's some data actually that I haven't presented here, but serial lactate within 90 minutes is quite predictive. But This is an analysis or sub-analysis, I should say, from the IBP Shock 2 trial that shows that a serum lactate after 8 hours was more prognostic than an admission lactate and more prognostic even than a area under the curve. So I think really incumbent on us to serially measure factors, and lactate, I think, being a particularly important one with a cutoff of about 3 that corresponds with a dramatically higher mortality rate. And I think really emphasizes that the early actions we take for shock patients are really critical. I alluded that a key theme in shock care was the heterogeneity, and here's another example of the heterogeneity. So this is the IVP Shock 2 risk score. They took 6 characteristics, including 3 laboratory values, so admission glucose, admission creatinine, and admission lactate, 1 factor from the cath lab. So did you achieve TIMI-3 flow after PCI? And you can see a low IVP shock score of 1 or 2 corresponds to a mortality rate that's about only 20%, only, I say, relative to the alternative, which is a high IVP shock score. It is a mortality rate at 30 days of about 80%, so dramatically different. In my opinion, there were 2 major opportunities for improvement of the IVP Shock 2 score. The first is that the trial didn't systematically include hemodynamic data, and we know that hemodynamic data is predictive of outcomes, especially in AMI shock. But secondarily, I just presented a lot of data that shock's very dynamic. And the IVP Shock 2 score really only leverages data from admission. And so while this is nothing as sophisticated as our friends and colleagues, Rohan Kara and team are doing, one of the things that our team has been looking at is leveraging the prolific time series data that we already capture in electronic health records to better prognosticate for patients with shock. And so our hypothesis is that in the first 24 hours of admission, we're getting a ton of data in terms of vital signs, labs, medication changes. And if we can integrate that using machine learning based algorithms, can we better prognosticate? And we found that we likely can. So here is a paper that we've submitted using this approach. And you can see that the area under the curve here is 0.82. In comparison, the area under the curve for the IVP Shock 2 model and the card shock model is about 0.71. And I think the value add is not only the enhanced prognostication, but the fact that such a tool could be easily embedded at the bedside, with particular use for institutions like Yale that partner with a lot of partner hospitals that allow for more rapid identification of clinical decompensation and then more rapid transfer to the mothership. I skipped over an important slide, one that Dr. Nana is a co-author on and has been a leader in the field for. And that is the importance of evaluating frailty as a potential risk modifier for outcomes. So these are data from the Cath PCI registry in which we stratified patients who are undergoing high-risk PCI by their frailty status. And this is based on the clinical frailty score. And so we binned patient based into 4 categories of frailty: non-frail, pre-frail, frail, and severely frail. And there are 2 key messages based on this slide. First is that there is a clear gradient of risk the more frail patients go. And the second, I'd like to focus your eyes on the red bars, which reflect patients who are severely frail. And you can see that they basically constitute a distinctly high-risk group patients for mortality. And so I think if we have the opportunity, and we can talk about this maybe offline, of evaluating frailty prior to undertaking a high-risk PCI, that would really help inform decision making and enhance our informed consent process with patients and their family. So let's review the past little bit that I've been talking about. So about the basics of cardiogenic shock. So cardiogenic shock is a very heterogeneous disease state in terms of both underlying cause, with MI and heart failure being the most common causes of heart failure shock, and overall prognosis. The natural history of disease for these two most common causes is very different. MI shock presenting with hypotension first, progressing to hypoperfusion, and then ending in congestion, and heart failure shock being almost the opposite, which is presenting with congestion, progressing to hyperperfusion, and then ending with hypotension. Shock is rapidly evolving and dynamic, with more than 60% of SCI-C shocks progressing rather to a higher SCI stage during their hospitalization. Serial lactates, especially the initial one after 8 hours from admission, is more prognostic than an admission lactate, and frailty may be an important risk modifier for outcomes in patients with cardiogenic shock who are of older age. Let's sort of talk about some cath lab technical considerations. This is focused again on our fellows. So when you are placing an Impella CP, there are two important concepts. One is the distance and the position of the Impella in the left ventricle. Our approach at our center is to try to go RAO at around 30 degrees, where the heart looks like a peristernal long axis. Ideally, when we if you want, you can use a J wire simultaneously on the aortic valve to sort of position there and identify where the aortic valve is. The ideal position is 3.5 centimeters from the aortic valve. And really the best way to identify this is a concurrent echo. So we do try to do an echo before the patient leaves the cath lab. And if you really want to, if you're doing a concurrent PCI or coronary angiogram, when you're taking an image of the left coronary artery system and you're looking at the apex or the wraparound of the LAD, you can see where, or pay attention to where the pigtail of that impella is placed. And the reason that that's really important, because of that second concept, which I think we, or certainly I, think about probably a lot less, but really need to be thinking about, and hopefully we'll make a case with some data that I'll present in a little bit, is that rotation and malrotation is really important. So the pigtail really ought to be directed towards the apex. You can torque it oftentimes in a clockwise direction to get the pigtail pointed away from the mitral apparatus. And malrotation is important because it can result even in some modest aortic regurgitation, some modest mitral regurgitation, can increase the risk of thrombosis, hemolysis, and suction alarms. And the suction alarms, let me just sort of highlight, because it will come, that will be an important theme that comes up in a little bit. So the ideal rotation of the inlet is oriented towards the apex, away from the mitral apparatus. And unlike position, right, if your impella is too far in the aorta or too far in the LV, there are no distinct alarms for malpositioning. And the reason that that's important is that can present with suction and hemolysis. So the suboptimal rotation can result in you being sort of entrapped in the mitral apparatus. And the key thing there is then to, from a technical standpoint, turn your support level down to P2 and try gentle clockwise rotation that can often sort of help modify that position. Let me ask actually really quickly, if the fellows have been in this scenario, what would you do if an Impella CP, when I say Impella, I mean Impella CP here, came all the way back into the aorta so that even the pigtail is not across the aortic valve? Does anyone have any ideas or thoughts?
Are we in the cath lab for it?
Sure. You can be in the cath lab. You can go to the cath lab if you want.
I mean, I guess if we're there, if it came all the way across, I'd probably drop it to P2 or something, and then try to see if I could just push it directly across if it was just popping out. If not, I would consider rewiring, and if we can't get it across, then have to remove it and swap it for a new one.
Yeah. So that was my sort of impression. You can push it and see if it prolapses down. It often doesn't, right? And it's built with nitinol, and so it can kink pretty easy. So you do have to be a little careful about that. We were in a case where that happened, and I just ended up replacing it, and I felt really bad about it because it's a lot of money to do that. And so there's some interesting, so then I read about it later, and there's some interesting approaches. So here is an Impella CP that was out. Like I said, just sort of pushing it at the bedside resulted in kinking. So this is a case that was presented. And so in this case, what Debu and colleagues had done was went left radial, took a 6 French multi-purpose guide and a 25 millimeter gooseneck snare, snared the pigtail, and then as a unit, both with the Impella and the guide, sort of guided that in to give it a little bit more stiffness. So I thought that was a really elegant potential solution. There's other thoughts as well. So this was a cool case as well. And what they did here in panel A, you can see is I think they went right radial, took a pigtail, crossed over into the aortic valve, then got just a regular J wire out. And by putting that J wire out actually here in panel B, what you're doing is you're tamponading open the aortic valve. And now that you have an opening, then pushed the Impella through and got it into a nice position. So I thought those were a couple interesting approaches for a problem that doesn't happen often, but I think is quite costly, especially in a sort of era where cost is being so carefully thought of, instead of just replacing an Impella, maybe rescuing one that had come back. Do the fellows have thoughts about this? So, I think that I have a whole slide deck on venting for VA ECMO. It's not uncommon that we are asked to vent after VA ECMO is placed. There are data that suggest that the timing matters, so that unloading first and then VA ECMO is more optimal. You get better unloading. But let's say that you don't have the luxury of time to do that. When someone's on VA ECMO and the afterload is very high, oftentimes there are challenges with ejection of the aortic valve. Thoughts on how to cross the aortic valve when a patient's on ECMO? It's fine if you don't have it. I'm just in the interest of time. What I'd say is, obviously, like if you're doing a TAVR, use a straight tip glide wire. We've tried rapid pacing, actually, that has been helpful. Similarly, borrowing from our structural colleagues. We've also done pushes of 1 milligram of epinephrine to recruit some of the native LV function, which has helped. And then probably on a more extreme level, something that we've done that you have to be careful about in not dislodging the ECMO cannulas is doing CPR and chest compressions to try to eject some forward blood flow. And then sort of get a wire across. We've talked about this. We've never had to do it. But I guess the other thing would be to go transeptal and snare a wire from that approach. All right, so that concludes some technical factors for the fellows to just think about as we are using an increasing amount of these devices, which brings us to sort of what is the evidence to use these devices, especially in a post-danger shock era. And, I think one of the things that was particularly glaring about the danger shock trial was the high rate of complications. And so how should we think about those? So just as a summary for Danger Shock, it was a trial that was conducted amongst non-comatose STEMI shock patients. So NSTEMI patients were not enrolled. It took 10 years to complete the trial, primarily being randomized in Denmark, but also Germany and the UK. Patients were randomized to a microaxial flow pump versus standard of care. And actually were required to keep the Impella in for 48 hours after it was placed. And as you can see, there was a statistically significant reduction in mortality, as we all know, with a number needed to treat of 8. There's a few key things that just to remind ourselves about that I think are pertinent. For patients who were younger than 77, the number needed to treat was only 5. So I think that that's notable. The other thing is that the upper bound of the confidence interval is 0.99, suggesting that really only a couple deaths here or there may have changed the statistical significance of the trial completely. How generalizable was danger shock? I think one of the reasons that it was positive was that the inclusion and exclusion criteria were very, very strict. And so our friends and colleagues at the Critical Care Cardiology Trials Network looked in the C3TN registry regarding how generalizable that population would be, and appreciated that only a third of STEMI shock patients would actually be eligible for danger, and only 5% of all shock patients in the entire registry would qualify for the trial. And so I do think that before we sort of charge forward with putting an Impella in for every patient with AMI shock, we need to sort of just recognize that the generalizability is limited. I earlier alluded to the fact that the number needed to treat was only 5 for individuals less than 77. Well, what about individuals that are older than 77? So this is a very interesting analysis that came out of Danger that looked at age as an important covariate for outcomes in cardiogenic shock. What was interesting is that across the age quartiles, there was no difference in a lot of the core things that we would think about, like blood pressure, lactate level, LVEF, or even SCAI classification at admission. However, there was a statistically significant interaction between use of a microaxial flow pump and age. And so let me focus your eyes down here. You can see that the relative risk that favors a microaxial flow pump actually is exaggerated at younger ages, sort of in the 50s and 60s. But that benefit really starts to attenuate as we age, with a crossover at about 77. So I think the most important thing that I would say here is we have to be very cautious about being ageist, and that the trial is certainly not powered to examine this question, but it does raise, I think, the concern that in the elderly, is there a real benefit? One, and then two, from the prior comment of frailty being an important risk modifier, certainly in our older patients, I think making another case that systematically measuring frailty may be valuable. So let's go back to that initial motivating case that I presented. It was the 81-year-old with an anterior STEMI who suddenly started to crash. So we ended up calling a code SART, which is our emergency anesthesia team. The patient got intubated. We immediately got right common femoral access and placed an Impella CP with some difficulty because of how tortuous the aorta was. We advanced the Xi'an blue wire across the lesion, placed some slow flow that we appreciated even after IVUSing, looking for a distal edge dissection, that we treated with some intracoronary epinephrine, and then placed a PA catheter that showed that despite the Impella CP, the cardiac index was still low. So this is the angiogram after that case, or at the end of the case, which again is reasonable. At this point, the patient was doing much better. And we said, okay, let's just pause. We'll send them upstairs with the Impella CP, and we're feeling pretty good about ourselves, right? This is why we do intervention. And so I was pretty excited talking to the family. And as I was on the phone with the family, the nurse called me and said, "Hey, Ajar, can you come look at this?" And she was moved from the cath lab table to the gurney. And in that move, there was an expanding right groin hematoma. And so we immediately held pressure. And then the question is, well, what do we do then? So I guess those fellows' thoughts on how you would manage this?
Get contralateral access, man, put pressure on it, and then probably take a groin shot from contralateral access to see what's going on.
Yeah, I think that's very reasonable, and I think we certainly could have done that. I think our thought was based on our PA numbers that we're going to need the Impella anyway, As we know, the inner diameter of the impella sheath is 14 French. The outer diameter is actually probably a lot closer to 16 or so, but the repositioning sheath is a lot smaller. So what we ended up doing was rewiring the impella sheath. We removed that device and actually upsized to 16 French Cook sheath. And with that, the bleeding stopped. Um, and then we replaced the Impella CP through that 16 French sheath. Now, with that, though, we appreciated a considerable diminution of flow in the right lower extremity in terms of pulses, and so we put a 6 French antegrade sheath in the right the right SFA, and then weaned the Impella support over the next 2 days, and she returned to the lab for removal. And then for the 16 French sheath, we did go up and over as you thoughtfully suggested, and did sort of a dry closure, and ended up using, I think, 2 per closes to get a good result. And this is the angiogram afterwards. You can see the balloon that we used to occlude there. But it is a case that I think really highlights the high number of adverse events. So these are the adverse events that were depicted in the danger shock trial. And you can see that for patients who were randomized to the microaxial flow pump, that the complications that were particularly notable were a much higher rate of bleeding, as we saw, a very high rate of renal replacement therapy, which I got to say was the one that, to me, took me by the most surprise. But certainly limb ischemia, even stroke, and certainly sepsis were important complications as well. With that said, I think it's important to remind ourselves that the fear of complications alone should not in isolation drive decision making. That despite those high rates of complications, there was still a statistically significant improvement in mortality. So in the months following Danger Shock's initial publication, we've been able to delve a little bit more into what happened with some of these complications. So bleeding in particular, what I thought was very, very interesting was that, unlike my case, only a quarter, or about 25% of bleeding in Danger Shock, was related to access site. Importantly, 5% was intracranial, so that's particularly important to be mindful of. The timing of bleeding events was mostly actually not in the cath lab. It was actually about half of bleeding was on mechanical circulatory support, and half of the bleeding was after it. So I don't have a great explanation, but to say that it's clear that the microaxial flow pump, to some degree, disrupts normal hematological function. This is the first analysis of complications that I've seen that did not correlate complication in shock with increased risk of mortality. And I'll show some data that sort of really counters that. So in contradistinction to these data from danger shock, data from culprit shock depicted that bleeding was both common and associated with significantly higher mortality. So a similar degree of major bleeding in culprit shock of about 1 in 5 patients. And if I focus your eyes on panel B, the blue curve reflects patients who did not have a bleeding event. And the orange curve reflects patients who suffered from severe bleeding, as defined by the BARC criteria. And you can see a dramatic drop in survival percentage for patients who suffered a bleeding event. And I think that's really sort of the 1-2 hook punch there that results in important distinction in what happens to patients. So, access site may be important. This is analysis led by one of our fellows, Dhruv Mata, using data from the CAF PCI registry, that for patients who had transfemoral access as compared to transradial was not surprisingly associated with lower bleeding events, less mortality, and less dialysis. I will say, I think part of that is confounded by severity of shock, which is not well captured in CAF PCI, but I think makes sense to go radial if you're not using an MCS device up front, right? If you're medically managing for, let's say, an NSTEMI shock. I think if you're using a microaxial flow pump in the contemporary era, it makes sense to just use that same site with single access. I would remind the fellows that when you're thinking about access site bleeding, most sheaths are conical, right? So if you're seeing or conical, if you're seeing bleeding, oftentimes the answer is actually to gently push the sheath in. That you have to be very careful not to overdo that. And then to maintain the sheath angle, you want to avoid unnecessary effort right on the proximal side. So we'll often put a little bit of cushioning with some gauze to maintain that angle when we're sending a patient upstairs with an Impella CP after leaving the cath lab. So I think those are really important concepts. I won't belabor the concept of ship for Impella CP because I'm assuming that y'all are very comfortable with that. But for the fellows, have you done any ship with ECMO? And I'll just continue for the sake of time. So we've started doing most of this, learning this from Naveen and colleagues. So here's a nice example of that. So here is the arterial cannula. You'll need a Y connector for this. And this is a 26 French dry seal sheath that we've cut very short, you can see here. And that's connected with some 3/8 tubing, actually. And then the other limb of the Y connector just connects back to the ECMO circuit. So in order to do ship with ECMO, you do need to be able to, the patient needs to be able to tolerate being off pump while you're doing this. You're obviously clamping both sides of the arterial cannula. You need a Y connector with some extra 3/8 tubing, and then a 26 French dry steel sheath that you have to trim aggressively. And then just be mindful of, depending on where you cut the arterial cannula, if you cut it, sort of proximal to where the connector is, the side port is, you'll have to replace it at the end. So you'll have to rewire with an Amplatz or a Lunderquist, take that out, and then put a new 17 or 19 or whatever French sheath cannula that you're using. Alternatively, if you are able to put the Y connector distal to that, then you may not need to replace it at all. All right. I told you that what surprised me was acute kidney injury and renal replacement therapy in danger shock. So that was published by Ulrich Zweck recently in Circulation. So one acute kidney injury was very common, occurring in about half of the cohort. It was higher in the microaxial flow pump arm, and the majority of renal replacement therapy was initiated very early, actually, within 24 hours. Unlike bleeding and danger shock, acute kidney injury was associated with increased mortality. But interestingly, in the long term, amongst all of the survivors, none of them were on dialysis at the 180-day mark. My initial impression looking at the data was, gosh, this high rate of renal replacement therapy is all explained by competing risk, right? You have to survive to have the privilege of getting on renal replacement therapy. But after conducting a Gray's analysis, accounting for the competing risk, the microaxial flow pump was still associated with a higher risk of renal replacement therapy. So I think that association between microaxial flow pump and increased risk for AKI is real. In the prior slides, I kept sort of hinting at this importance of suction events, and here's where it becomes important. So when Jakob Muller and colleagues looked at the risk factors for AKI, there were the obvious ones: shock severity, bleeding, baseline, GFR. But two that are potentially modifiable that I've bolded here. The first is suction events, which I kept alluding to, and the second was a longer duration of support. And so interestingly, in speaking with Jakob about the trial, one of the things that he said in retrospect that he would have considered doing differently about the trial is not mandating that there was a 48 hours of microaxial flow pump support after randomization, that, weaning should be allowed whenever the patient was clinically allowed to do it. So I've got to say, in following these patients in the unit, I had been dismissive of suction events, but I'm much more mindful of them based on these data now. So one of my colleagues likes to tell this to our fellows, suck less, and that's what I would say for our Impella CPs is that they should have less suction as well. Most of the data on complications that I presented were from randomized clinical trials, but I also just told you that only a third of STEMI shock would actually be eligible for danger shock. So these are data from a registry, which is more reflective, I think, of actual practice. So we published this using data from the cardiogenic shock working group, specifically looking at acute limb ischemia. And I guess let me highlight three key findings from this analysis. One was that the rate of acute limb ischemia was about 5 to 6% in this registry, which corresponds to what was seen in the clinical trials. Another point that is actually not in the slide is that about 5% of all acute limb ischemia was actually in patients who were not on mechanical circulatory support. So there is a proportion of patients with shock who don't have MCS who also get acute limb ischemia, presumably from embolic phenomena or just from vasoactive medicines being so high on top of existing peripheral arterial disease. Second key thing is that if I focus your eyes on the figure, you can see the red bars reflect patients who had shock and acute limb ischemia versus the blue bars that reflect patients who had shock and no limb ischemia. You can see a marked difference in in-hospital mortality that persisted even after accounting for other confounders. And then when we look at risk factors, they're mostly things that I think we would have thought about as clinicians. So female sex, history of peripheral arterial disease, need for renal replacement therapy, and the use of more than one mechanical circulatory support device. All right, so talking about acute limb ischemia, this is another sort of interactive case for the fellows if you're willing to engage. So 76-year-old gentleman who presented with an anterior STEMI, clear sky C shock. We put an Impella CP, used a ship approach, treated the mid-LED again. At the end of the case, we weaned depressors to sort of moderate dose norepinephrine, put a PA catheter, which again is our practice, showed a pretty low CPO. And so we said, hey, we'll keep the Impella CP in, send them up to the unit. Again, was feeling really good about ourselves. And in 48 hours, the CP support was weaned or on minimal pressors at this point. And so the decision was to take the device out. And so we brought them back to the lab as we do systematically, used a post-close approach, put two per-closes in, and then we're about to sort of be done when we measured the pulses in the right lower extremity, DP and PT, and couldn't feel any. Put a Doppler on there, couldn't appreciate any. And so there was a left radial A line. So we went in from the radial and took a picture, and this is what we saw. So at this case, or at this point, what would the fellows do? I'll let that play one more time.
Contralateral groin axis and cross to the right femoral artery. Try to open that. I think it's probably shut down by the per-closes.
Yeah, I agree. And that's sort of exactly what we did. So we went, we put a 6 French sheath in the left common femoral artery. We took an omni catheter, and a glide wire down. We took a 4 French glide catheter. We exchanged the glide wire out for a Rosen wire, advanced a 7 French Ansel sheath to the right external iliac artery. Through that, we took that same 4 French glide catheter and then used a 014 Pro Water to probe the lesion. We got through and advanced the glide catheter. Where are we right now? Yes, we're in the profunda actually, right? So we pulled back and we got one wire down the profunda, sort of as a safety wire, and then we got another Pro Water down the SFA, And then we actually exchanged the Pro Water and the SFA for an embolic protection device, anticipating that there may have been some thrombus that had started to develop there as well. And what we didn't want is to distally embolize some of that thrombus as we were trying to open up this area. So we used, I think, a 6.0 balloon initially. We IVISed, and then on IVIS, you can see that there was actually a big dissection flap. So we upsized in 8.0. It still looked a little ratty. And because I think of how, the fact that he just was sort of evolving from cardiogenic shock, what we didn't want is for that dissection flap to open things back. And so we ultimately made the decision to deploy a 9.0 by 40 self-expanding stent. Which obviously is more flexible and suited to a tortuous or tapered vessel in the common femoral. And this is what it looked like at the end. All right, so I think my suggestion for the fellows is, as you leave to the auspices of Yale, or some of you may have the privilege of staying on, is to think about sort of a systematic or algorithmic approach for complications. This is sort of one that we've put together, and I say this because we know that sepsis, the last one, that sepsis is actually pretty common in this population, is that I think that we should study a trial for prophylactic antibiotics for patients who are presenting with shock and certainly with arrest. So let's summarize this. Sort of complications are common in cardiogenic shock, with bleeding, acute kidney injury, acute limb ischemia, and infection being particularly important, and tend to be associated with an increase in mortality. A sub-analysis from danger shock suggests the possible attenuation and benefit of a microaxial flow pump with increasing age and potential harm among adults older than 77 years. The trial was underpowered, so be very careful of engaging in ageism. In danger shock, only a quarter of bleeding was actually access site related. Even accounting for the competing risks, renal replacement therapy was more common in patients with microaxial flow pumps. Suction events and longer duration of support is associated with a higher risk of AKI, so being very disciplined about suction events, and as a consequence of that, from the prior section, thinking about positioning and malrotation as causes of suction events. And then for longer duration, engaging in daily weaning trials is critical. And then finally, fear of complications should not in isolation drive decision making, and a checklist or algorithmic approach may mitigate some of those risks. All right, so here's the wild tangent, which are some data that we will actually much more formally be presenting at SCAI. But I think, since Jen had suggested that this was oriented towards the fellows, I want you guys to start thinking about this, which is the orthopedic risks to you at an early career stage. So very recently, the 2023 SCAI survey in occupational health hazards was published. 2/3 of individuals describe musculoskeletal pain secondary to wearing lead or working in the cath lab. 60% of individuals stated that they had at least one orthopedic injury, with 1/3 of individuals, this is respondents, saying that they experienced a lumbar spine injury. And in fact, 20% of respondents were forced to limit their time in the cath lab, which is staggering. Now, this is despite the fact that 80% of respondents were partaking in some preventative measures, and those preventative measures included strength training, aerobic exercises, or stretching or / yoga type approaches. And even for radiation-related things, there were a 3-fold higher risk of either cancer or radiation-related injury like cataracts compared with the general population. And so our group became sort of really interested in thinking, well, gosh, what data exists quantifying the ergonomic risk on cath lab operators. And so we ran a single center prospective study called ErgoCath, where we started quantifying the ergonomic strain on cath lab operators stratified by the use of traditional lead versus the Rampart Inc. system. We used a variety of different tools and studied a variety of operators. So attendings, fellows, we have PAs in the lab as well. And then we did a sub-study looking at techs and nurses, hypothesizing that they would have sort of different strain patterns. And again, this will be more formally presented at Sky, but I thought I would share sort of two key findings. One is that the cervical joint was in a high risk position for about a third of case duration, so specifically axial rotation at the cervical joint level, which is quite staggering. And second, and this again is geared towards the fellows were placed in a higher risk position more frequently than attendings. So you can see statistically significantly, this is specifically looking at the cervical joint. We looked at other joints as well. So the thoracic, spinal, the lumbar as well. And those are data that will come later. And so the question is why? And so this is a view from the Neuraxon screen. Neuraxon is the company that we collaborated with for the ergonomic equipment. And you can see this is us measuring Dr. Gaetani, who's one of our fellows. This is actually during an Impella case where we're taking that peel away sheath out. I'm comfortably on the other side, advancing the repositioning sheath. But you can see the stresses on Dr. Gaetani's spine, at the torso pelvis, at the cervical side, and on the thoracic level as well. Why does that matter? Well, even modest deviations from the neutral position result in dramatically higher spinal loads. And for us, we are already experiencing a high load due to the lead that we're wearing. But you can see here at neutral position, there's about a 5 kilogram load on the cervical spine. But even only a modest sort of bend of about 30-degree flexion of 30 degrees results in a more than threefold increased force to the cervical spine from 5 kilograms to 18 kilograms. What about for radiation? So cases with Rampart had marked reduced radiation exposure to operators, so 0.5 millirems compared with 55.8 millirems wearing traditional lead. So what can we do? Well, there's a variety of new options. The primary barrier to adoption is cost and administrative hurdles. So what I would suggest, again, to the fellows as you're looking for jobs to advocate for yourself, there are a variety of new technologies that I won't have the time to delve into, but happy to talk to people offline. This is a study from the Mayo Clinic that looked at a tailored 15-minute daily stretching approach amongst cath labs across the different Mayo campuses, and suggested that this 15-minute daily tailored routine reduced neck and back pain. So I will actually just leave this slide up because I realize I have 5 minutes and I actually have to drop exactly at 8:30, but I'll leave 5 minutes for questions if anyone has any.
Thank you so much. That was a really great talk, Ajar. I think that it's really important to talk about this, especially with the change in the guidelines right now, or the more recent update, I should say. And I think the complications will go down as we have more technologies being developed that are smaller sheath sizes will help a lot. One of the questions that I have is that we treat acute MIs outside of this hospital system. And there are certainly limitations within those type of cath labs, but I think the benefit of getting something like an Impella CP in those patients is to do it as soon as possible. What do you have any suggestions as far as how to help implement something like that at a smaller place while you wait for them to be shipped over to the larger hospital and trying to still get that ventricle unloaded in a timely fashion?
Yeah, it's a great question, Jen. Thanks for asking it. So I will say, one of the cardiogenic shock working group analyses that I had the privilege of being a part of was actually looking at contemporary balloon pump use. And what was very interesting was that the rate of mechanical circulatory support device uses, that balloon pumps are still very, very highly used. And the majority of the balloon pump use were from sort of smaller hospitals that are transferring into major hospitals. So I think that in contemporary practice, a lot of other sites there's just higher comfort with balloon pumps. But I agree, right? I think that the majority of benefit, especially in STEMI shock, is early unloading. And so I think that that's an implementation problem, right? I think ideally, you're learning a lot of these concepts when you're not in the throes of shock or an emergency, right? So I think that that may mean partnering with our colleagues who are at sites that don't do this as much, and having them come in, or us proctoring them on deploying a device for like a high risk PCI case, as opposed to in a STEMI. As you know, the average PCI volume of an operator in the US is 50 PCIs, right? But look, the majority of AMI shock actually goes out to community hospitals. Like we at the Brigham do 70 to 80 STEMIs a year, which is very low volume compared to sort of other sites. So I think it's going to require a lot of very deliberate collaboration. And I think for systems like Yale or for us, it will be it has to be sort of led by higher volume operators who go and then I think help with proctoring and so forth.
Great, thank
Can I make
you.
a can I make a quick question, Ajar? That was a great summary. Thank you so much. In terms of system based, does the Brigham have super users, or meaning like are there dedicated shock operators for
Yeah,
these
it's a good.
cases?
It's a
Uh,
great question. Not really. I mean, it's sort of my area of interest, and so I think during the day, a lot of things get sort of shunted towards me, but it doesn't have to be the case. Again, because there's 7 of us who are operators. If I'm not on call or away, right, like anyone can end up with this, and so I do think that there is a certain baseline of comfort, even deploying ECMO that we've now developed as a group. But I think if there, certainly if there's questions or things that's directed to someone. So yes, I like at the Brigham, I'm the sort of cath lab liaison for shock related questions and for the shock team. And so during our monthly reviews, multidisciplinary reviews. That's sort of my role. But I do think that everyone both is very skilled and I think comfortable with at least the sort of big picture devices,
and a
and that
follow-up question
includes
to
our RV support as well.
Yeah, and a follow-up question on that is: do you see the role of the cath lab changing with ECMO now, with new cannulas coming down the pipeline?
Yeah. So I'm gonna have to drop off. I apologize in a minute, but I would say yes, absolutely. I've got our surgical colleagues are wonderful and very talented, but I've got to say a huge pet peeve of mine is deploying ECMO at the bedside when you have the luxury of time to come to the cath lab. And I've got to say, like the number of times I've seen, for example, even something as simple as putting in a distal perfusion catheter that ends up in a vein or in a subintimal tract because we haven't checked right using fluoroscopy. I think that there is a huge role for ECMO in the cath lab.